Hi, everyone. This is the Managing an IoT Landscape in Healthcare with FHIR. Our presenter today is Bob Pratt. Please note that if you are on Zoom, the chat function in Zoom is disabled, and we are taking all Q&A in the Whova app. Under the presentation, you'll see a Q&A section. You're welcome to put questions in there. And then for those of you that are live in person, we will have approximately 5 minutes at the end of this presentation to take questions as well. With that, I think we're ready to go. Bob, are you ready?
I am ready, Andrea. Thank you very much.
You're welcome.
Let's begin.
Good day, everyone, and welcome to this DevDays presentation of Managing an IoT Landscape in Healthcare with FHIR. My name is Bob Pratt. I'm a Senior Advisor, Healthcare Informatics Architect for Northwell Health. At Northwell, we have a team called the Northwell Emerging Technologies and Innovation, or NETI. The NETI team is chartered with exploring new ideas and new technologies within the healthcare space, evaluating those, doing proofs of concept, partnering with other companies who are introducing new ideas, doing pilot programs, and eventually moving certain ideas that have good value and good promise into production. One of the projects that we have been involved with for the last couple of years is this notion of remote patient monitoring. This project really got started back in the early days of COVID during the pandemic, when it was quickly became apparent that patients needed to be isolated from others, and the traditional notion of patients sitting at the bedside was not going to be viable for all the reasons that we understand. So we took on a project, and we collaborated with a company called Celaborate, based in Kosovo and in the US, to introduce a remote monitoring program using a device that they designed and built and market called the Hello 2 camera. The Hello Healthcare system and its camera, the Hello 2, is a small self-contained device. It's Android-based, and it can be placed in a patient room in a variety of orientations. It can be put on top of a TV. It could be mounted to the wall or hung from a bracket in the ceiling. Really, because it's small and easily mounted, it can be just about anywhere. And it's primarily a camera, but has a lot of other features too, which we don't have time to go into today, but has many features that can be leveraged as well, including AI, to do alerts and so forth for falls and things of that sort. These cameras are then remotely monitored, and a single observer station can have up to 32 different views of 32 different cameras in patient rooms. So this was the project that we started out with, and in this discussion we'll talk about some integration with our EMR and the use of FHIR. On this slide we have a couple of examples of what it looks like in the patient room. On the left is the sort of the home view, where if the patient wasn't using the TV for some other reason, watching a movie or catching up on the news or something else, they would see this view. This view and then the TV itself are managed by the camera, so it can do entertainment and other things as well. But this would be sort of the default view. You can have vital signs here, upcoming appointments, and various other tiles that can be arranged on the screen. On the right-hand side is a three-way conversation. So we have a caregiver, a nurse perhaps in the room with the patient, and the Hello 2 camera on the TV and the monitor. And in this case, there's a third party or another provider who has dialed in, and they've created this collaboration of the three of them with the Hello 2 camera. And also on that view on the left and right side are some information, some tiles that could have, again, vital signs or other information. From the observer side, so this view here is an observer somewhere remotely away from the patient rooms that is looking at a screen on the left with 16 different cameras, so 16 different patient rooms. And they have the option of various options here, which I won't go into in a lot of detail due to time, but they can zoom in on one particular one. They could start that third-party call that we were showing and look at information about the patient, even interact with the patient, talk to them, and so forth. The cameras themselves have the ability to integrate with EMR systems. In our case, we took a different approach where we wanted to leverage a universal interface and use FHIR as a means of transmitting data back and forth, to adopt that standard between our system that is going to be looking at our EMR and collecting information about patient admissions and discharges and transfers, and then bundling data together that can be transmitted over and make that an extensible model, a standardized model. And FHIR was really the natural choice for a variety of reasons. But the adoption of that standard really gave us a good way to communicate back and forth in a way that we could change and extend that model, add data, take some data away, do whatever we wanted, and not have to rewrite or write a standard in order to do that. So what we needed in the end, with all of that was all great, but what we needed was a way to link the patients and the movement of patients in and out of rooms to the device. And that's where FHIR and various FHIR resources I'll speak about in a moment really came into play. From an architectural perspective, this was what we built as a proof of concept, and now are piloting this, and we'll go into full production mode very soon. On the left are the various systems, EMR, registration, so forth, that feed into our data platform inside of Google Cloud platform that consists of a FHIR repository. So every message, every HL7 message that flows through our health system is collected and forwarded on to a FHIR repository in the Google Healthcare API. That is then in turn forwarded automatically into BigQuery. Pardon me. And there are other sources too that don't necessarily use HL7, and we collect those and transmit those into BigQuery as well. So we build a really robust warehouse of information that we can tap into to forward on to the Hello Healthcare system and to the cameras. The cloud function then manages all of that. It runs and is waiting for messages to come in, ADTs to come in. When we see that and we see a patient has been admitted into a room that is one of the ones that we know that there's a camera in, we will take that, associate it to the camera device serial number, bundle that up with the patient data, and forward that through a REST API to Hello Healthcare. That in turn then is displayed on the observer station, so now they'll be able to see who is in that room and maybe other information about that patient, and also in the patient room itself. The view that's on the display will have that patient's name, so anyone in the room could, and this other information too, pending privacy issues and so forth, whether it actually gets displayed or not. So FHIR to the rescue in this. The resources available in FHIR are really key to enabling this automation between our EMR and the Hello 2. Front and center in that is the device resource. The device resource is pretty broad in scope. You can really define any kind of a device that you want, be it a vital sign monitor, an infusion pump, a bed, or really anything that you consider a device, you can define within a device resource. In our case, we're defining the Hello 2 camera. We built an identifier system, a coding system within Northwell for different things, different uses, but one of those is defining these cameras. And so we have an identifier for the camera that's in a coding system, and we have its location and its serial number. We have really everything we need in there in that device resource. The key thing that I just said, and I'll repeat that, is the location. So location is what allows us to start from an ADT and work our way all the way to an actual device, an addressable device that we can send the message to. So location is that key resource. Location defines every physical location. Every bed in our health system is defined in a location table or a location resource. Sorry, and it is actually in a table in BigQuery as well. And then in that location, we'll see a detail of that in a moment. We're able to match an ADT message that has the specific, for that encounter, has the specific room and bed and so forth, and link that back to the device. List is also very useful. In the interest of time, I'll probably not talk too much about list, but list is good for just keeping a list of all the devices that you have, and even building a taxonomy of devices. So the device resource is shown here in a fairly trimmed down, simplistic form, but the key things are there, which are the identifier, what this device is, its serial number, because at the back end on the Hello Healthcare side, that's what they use to route this message to the proper camera, and the location resource link here is really the key, and talked about that some more, but that encoded location is defined to a specific place in the hospital system, to a specific bed, and then we can backlink from an admission message through the location and then back to the device. List is, as I talked about, list is a list, and it is useful, but I won't talk more about that. And location is really key as well. So location is where we have the specific parsed parts of the location, the facility and the unit or ward and bed, floor, room, and so forth. And then when we see that, we match that, and then we say, okay, well, this is this specific location encoding in our coding system, and then that allows us to go back to the device and get that specific serial number for the device. So the result of all of this is the view that you see now here, which is very different from the view we saw before. The left-hand navigator was not shown in that other view, but it's just, slide in and out. The left hand is a navigator where you can bring different cameras in and take different cameras out of your view. Again, up to 32 cameras at a time. The camera views themselves, but now have the patient's name and also a piece of data. And this data, I talked about extensibility before, but the use case that we had, which we were piloting, was to go out to the medical record and for this encounter and find the fall risk indicator, and then be able to show that and colorize it as well, so that at a glance the observer could see what the risk is to a particular patient, and that would give them more emphasis perhaps on certain patients versus others in the context of fall prevention. The left-hand navigator is also customizable and can have the patient's name in it as well. This particular view it does not, but it can have the patient's name there as well. So if you were looking to add a specific patient, you don't have to know what room that they're in or what camera they're associated with. You can we just go and find their name and click the plus sign, and that would now be on as a tile on the right hand side. So this is a big productivity gain for the for the caregivers, particularly the nurses and the observers who are managing these patients day to day. So in summary, FHIR has really made this all possible. We are seeing an increasing demand and interest in these devices, escalating in our health system, and it certainly just exacerbates the need for this kind of integration. And I don't only see this getting more robust in the future with more kinds of data being passed over and different use cases all the time. We're hearing different use cases which are modifying the result of what we do here, but it doesn't change the standard. It doesn't change the bundle. It doesn't change anything that we do. It's just another piece of data, and that's what FHIR does. It provides that standard. It provides that robustness and that extensibility to be able to solve these kinds of problems without having to change lots of code. You simply add another condition or add another observation or add something to the bundle, and you're done. So it's been really an interesting project, and I do appreciate you guys listening today. And if you want to reach out to me with questions, feel free to email me, and I hope you have a great day. Thank you.
Thank you, Bob. So we do have about 4 minutes for questions. Bob, I'm not sure if you were able to see, there are 2 on Whova right now. The first one is, are you caching any data on the edge location? Also some MDI aggregator map to bed location. What if the patient was removed from that bed?
Sure. Yes, thank you. Can you hear me okay?
We can.
Okay, so for some reason, I'm not able to respond to these questions on the Whova app. I don't know why, but I will answer them for us here. The first one, we are not doing any caching currently, but that is something that is possible. It may be an advantage in the future. So that's a good question, but no, we're not currently. We're running this interface periodically every minute or so. It wakes up and it checks for new ADTs, but the location data itself is not being cached. I'm not sure about what MDI is. We could talk offline about that. But when the patient is removed, so there is the unassigned and assigned. So the assigned part is if the patient is admitted into the room, then their data is there. If the patient is unassigned, that information is wiped from the device and from the camera system. So the bed would then become just empty and unassigned.
Okay, and the asker clarify the medical device.
Medical device aggregator map to bed location. So I think the camera system itself can have medical devices attached to it through Bluetooth. I'm not sure if I'm getting to the question, but perhaps we could go offline with this question in more detail.
Okay, and I do want to be able to ask anybody in person if they have any questions. Feel free to have a mic as well.
Do we want to go to the next question?
Yeah, a quick one, hopefully. Did you also explain about sending data to the device using FHIR? I might have missed it in case you did.
Sure. Yeah. Just briefly. So we use the bundle. We use a FHIR bundle, and we bundle together 3 resources: the patient resource, which we trim down to just what is necessary for the use case, and then we have the device. So that device resource that I showed you before, that's part of the bundle. And then any conditions or observation data would also be included in that bundle. And that's a REST call that we negotiate between our cloud function and the Hello Healthcare system. It's not a FHIR per se API, but it is using the FHIR standard and a bundle to transmit that data.
Okay, maybe one last question we have here on Whova. Do you tie location to user permissions, i.e. certain users can only see certain cameras in certain locations?
Yes, that's an excellent question. I'm glad we got a chance to answer that one, and the answer is a definitive yes. So the whole system, the whole camera, the remote monitoring system is based on a unit and at a unit level of granularity, and only certain users can see beds within a certain unit. So if I was not assigned to a unit and I tried to somehow look at a camera that was in a unit elsewhere, I would not be able to do that. So the answer is yes. There is a very fine-grained control over who can see what cameras.
All right. Well, I believe we are at time now. So again, thank you to everybody who attended both on Zoom and in person. And thank you to Bob for an excellent and engaging presentation. And if anyone does have additional questions, please do either contact Bob directly through Kuba, or you can use the Q&A box in the session. Thank you again, and have a wonderful day.
Thank you, everyone.